Right to go, everyone?
Thank you.
Yep. Okay, well, thanks everyone for coming along today for a significant announcement. And we'll hear shortly from Deputy State Controller Adam Horsburgh, who is also the CEO of Austin Hospital, and Susan Harding, who's the ED Nurse Unit Manager at Royal Melbourne. So we'll hear from both Adam and Susan in a moment, but firstly I'll take you through all of the numbers before the announcement. In terms of vaccinations, 24.8% of Victorians 18 and over have had 3 doses. That's an increase from 24.4% yesterday. The number of Victorians 12 and over have had 2 doses, and that remains at 93.2%. 20,562 doses were delivered yesterday at state sites, with 5.3 million in total. 5,211 were children aged 5 to 11. In terms of bookings, 115,000 bookings have been made in the last 7 days. 77,000 of those were for the booster. 36,000 were for first dose for children 5 to 11. There are currently 175,000 appointments available in the system over the next 30 days for people aged 12 and over, and 44,000 appointments are available for children 5 to 11. Yesterday there were 33,000 appointments available, so we're continually adding bookings that are available for parents and carers. So please, if you have not booked your child in for a vaccination, please do so immediately. Among people with COVID-19, 1,152 people are in hospital. That's a fall from yesterday's number of 1,229. 127 people are in ICU. It was 129 yesterday. 43 are on a ventilator, and it was 38 yesterday. Sadly, 22 people with COVID passed away. 11 of those people died in the last 2 days. In terms of case numbers and tests, 11,747 people reported a positive rapid antigen test to the coronavirus website. 62% of those tests were undertaken yesterday. A further 8,433 people received a positive PCR result from 39,725 tests processed. That gives us a total new case tally of 20,180, and there are 235,035 active cases, both PCR and RAT. 50,000 rapid tests were handed out across 69 centres yesterday. So they're all of the latest figures for you. But today we're making a significant announcement about Code Brown activation across our health services. We've been saying now for some time that our hospital system is under extreme pressure, and the risks we're now seeing in COVID hospitalisations are testament to that. So we've reached a point in our health system where it's juggling severe workforce shortages. We've got more than 4,000 healthcare workers unavailable right now, alongside a vast number of patients with COVID-19 who require hospitalisation. Alongside that, an extraordinary workforce that are absolutely exhausted. So we've always known that this would be the case, that as we move away from lockdowns and remote learning, there will be a strain on our hospital system, and we are seeing that play out particularly with the significant numbers via the Omicron wave. This is all happening alongside the continued need to treat patients with urgent and emergency needs. The initial measures that we've put in place is helping to ease the pressure, and that has served us well so far. But our busiest hospitals have asked us to go forward as we approach the peak of the current Omicron outbreak. And whilst it's good to see hospitalisations slightly lower today, you've got to look at the trend and where we're going to head to. They've basically been steadily climbing over the last week or so, and we know that the biggest increases are yet to come. COVID hospitalisations are already at record levels, and as we've seen in New South Wales, that's likely to increase by around 100 people per day. So if you think about, and as Professor Sutton was talking about yesterday, we will see the peak in hospitalisations and ICUs over the next 2 to 4 weeks. Hospitalisations lag a few weeks behind the peak of the numbers, and then ICU follows on from that. So if we see what we've been seeing in New South Wales of 100 a day, we could well get to over 2,500 hospitalisations and more over the next few weeks. So now is the right time to implement this plan. Now is the right time to act. Of course, having said all of that, the more people who get their third dose, the more children who are vaccinated, the lower the number in our hospital system will be. So we've got to manage our health system as best as we can, but at the same time, the best thing that people can do is to get your third dose or get your children vaccinated. So we need to continue to ensure our hospitals are ready to treat the worst cases in the most ill patients. That's why we're taking the next step of announcing a coordinated pandemic code brown across all public metropolitan and major regional hospitals from midday tomorrow. And as I said, it is the right time to do it now, not wait for a code brown until 2 or 3 weeks down the track when we're seeing the impact of the peak of Omicron in hospitalisations and ICU patients. We've got to act now. In terms of our regional health services, we're talking about Barwon Health, Grampians Health, Bendigo Health, Goulburn Valley Health, Albury Wodonga Health, and Latrobe Regional Hospital. So this coordinated approach will help ease the pressure on individual hospitals by better sharing the load across our system through prioritising resources, redistributing patient demand across the system, and managing workforce shortages. So what does it look like? It will look like things such as redeploying staff to work in areas of highest clinical priority. It means prioritising the offload of ambulance patients at EDs to get paramedics back on the road as soon as possible. It means things like changing services to free up staff, including the delivery of outpatient services outside of the hospital. For healthcare workers, this means they might be performing different roles than usual. They might be working in different parts of the hospital, on different rosters, and it might mean consultation with staff about some of their leave arrangements. So for example, a nurse or doctor who normally works in elective surgery, which has been scaled back significantly, can now be redeployed, for example, to an emergency department where the caseload is much higher. So the compounding pressures on our health system mean that there may be changes to the way services are delivered, but importantly, these decisions, in fact all clinical decisions, remain with the clinicians. For example, some less urgent services, such as outpatient appointments, may cease, or the delivery may be outside of a hospital setting. There also may be changes to the frequency in which patients can access certain services. The changes will give hospitals greater flexibility to prioritise services and free up additional staff to care for those with greatest need. Importantly, health services and the health workforce will continue to have responsibility for clinical and operational decisions that impact patients, and the sickest patients, as has always been the case, will be treated first. So what this means is that from midday tomorrow, hospitals will activate their individual code brown plan. So every hospital already has one in place and they're ready to go. From midday tomorrow, all of these health services will activate their individual plan. Health services will manage increasing demand, and I want to thank every single one of them and all their staff for their ongoing efforts on our front line. Health services are well prepared for this. They have their code brown plans in place and they know what to do, and Adam will speak about this in a moment. In order to support the health services, throughout the pandemic code brown, our hospitals will have the support from the department's new Health Service Response Centre. So we've had code browns in the past. We've had it with individual hospitals with the thunderstorm asthma event. We've had hospitals implement code brown during the Black Saturday emergency. This is the first time we're having a system-wide pandemic COVID Brown and why we need this response centre. So the centre will have an overview of what is happening in all of our hospitals to help coordinate patient flow and distribute patients across the hospital network. The centre will also support decisions around service reconfiguration, such as suspending particular activity or moving to home-based care, helping to make those calls when all other options have been exhausted. Additionally, we're expanding the amount of COVID streaming sites to increase the number of hospitals caring for coronavirus patients. This will mean more hospitals sharing the load as we deal with this extraordinary demand. So, as I said before, we're joined today by Deputy State Controller Adam Horsburgh, who will head up this centre and who can speak to what a Code Brown will mean on the ground in our hospitals. And Adam's also the CEO of Austin Health, so he knows better than anyone else what changes will be implemented. We're also joined by Susan Harding, ED Nurse Unit Manager at Royal Melbourne Hospital, and Susan will be able to take us through her experiences of herself and her colleagues in terms of dealing with the cases as they have spiked and how these changes will help them. So I'll hand over first to Adam, then we'll hear from Susan, and then we'll answer any questions. Thank you.
Thank you, Minister, and good morning, everyone. As the Minister has said, our healthcare staff and our healthcare system have achieved incredible things over the past 2 years. But as the number of Omicron cases has risen over the past few weeks, our healthcare system has come under increasing strain. Omicron cases and admissions to hospital are now approaching 1,500. And on any given day, we have approximately 5,000 healthcare workers who are not available to work. Added to this, we're all experiencing challenges with our supply chain. So in that context, we're taking this step, a first for Victoria, to call a coordinated Code Brown. And while it is a first for Victoria, it's also a necessary step so we can help face the challenges provided by both the caseload numbers and also the workforce shortages that we're experiencing across the system. So Health Services has been considering calling a Code Brown for some time, but we believe that now is the right time to action this. All health services have existing and well-established plans for calling the Code Brown to help respond to external emergencies. In this particular Code Brown, individual hospitals will respond and operate the Code Brown slightly differently in order that they can respond to unique local demands and challenges. Having said that, there are a range of options available to all health services under the Code Brown. This may include ceasing or reducing non-urgent clinical services, such as some outpatient appointments, or looking to provide care increasingly outside of the hospital. Staff may be asked to work in different parts of the hospital or to undertake tasks that they would not ordinarily perform. So there's no doubt that over the past 2 years we've asked an awful lot of our healthcare staff, and it may be that over the coming weeks we have to ask even more of them. This may include the option, if we get to that stage, of asking staff to defer some forms of leave. However, is it important to stress that we will only do this if absolutely essential, and we will do this in consultation with the staff themselves. For that reason, we have asked hospitals to consult directly with their staff to help develop sustainable plans to address the workforce shortages that we're seeing across the system. Under the Code Brown, hospitals will retain accountability for making operational and clinical decisions at the local level. However, they will be supported to do this by the Department's Health Service Response Centre. This centre will help to coordinate patient flow across the system, act as a point of escalation for issues and challenges being faced, and will also provide the ability for us to have a picture across the whole system of what Omicron is meaning for our health system. I will head up this response centre. It will report through to me, and it really will be an essential part of how we face the challenges over the coming weeks. So in addition to being the Deputy Controller, my substantive position is as the CEO of Austin Health. And in that role, I get to see every day the pressure that the system is under and the decisions that our frontline staff are having to make in order to prioritise care for those patients who most need it. Like every health service, at Austin Health we're having to make decisions about which services we may slow down or suspend for a period of time. And like everyone, the Code Brown will assist us to make those decisions and to communicate both to our staff and the community the rationale for why we're making those decisions. Finally, at a system level, it's important to stress that we'll continue to review this position on a daily and weekly basis. And it's our commitment that we'll start to unwind some of these Code Brown settings at the earliest opportunity when we believe it is safe to do so. Thank you. I'll now introduce Susan Harding, the Nurse Unit Manager at the Royal Melbourne Emergency Department.
Thank you, Adam, and thank you for the opportunity to speak today. I really want to take the time to thank everybody for their consideration in activating this Code Brown response. It is something that the Royal Melbourne Hospital is very supportive of. We've spent the last 20 months managing this evolving crisis, and we're ready for that next phase now. From a staffing and workforce perspective, we have spent the last 20 months considering the options of the community and what they needed, and what we're asking for now is that the community take into account what we need as a workforce and as a healthcare industry. This is a really important message that we're sending by activating this Code Brown, because we absolutely need to safeguard the resources that we have for time-critical emergency department presentations. We absolutely welcome the presentations of patients that absolutely need to be there, but they must be time-critical and they must need the specialist care that the emergency department can provide. If people don't need that, then there are a lot of community resources available, like GP clinics, virtual online telehealth appointments. There's Nurse on Call. There are a lot of community organisations that have been set up. We have a lot of resources at the Royal Melbourne that are available to the general public to access around COVID information, giving them information about what is the best process to follow. What we don't want is for people to unnecessarily present to the emergency department. I can absolutely with confidence say that if people attend clinics or services and their care requirements are beyond what that service can provide, they will be on-referred to the emergency department. So we are asking people to make good decisions. I think we've been challenged in the last couple of weeks, and what we don't want to do is put our healthcare service under further pressure. We had a patient last week that was desperate for a PCR. They called 000, called an ambulance under the guise of having chest pain. They presented to the emergency department and were fast-tracked down to a resuscitation room, at which point they declared that they didn't have chest pain and they really wanted a PCR and wanted it quickly. That is an unbelievable misuse of resources, and that, you know, as I said, we really need to stress that if you are unwell, you need to come. This is very different now to how it was 20 months ago. We had an environment where we were in a state of lockdown and we saw our general core business reduce significantly, and we were afforded the time to take the time to manage our COVID needs. And now what we're seeing is trauma, work cover, TAC, all of those what we call core business workflows are back up, and we're trying to manage that as well as COVID presentations, which are significant at the moment. Staff are exhausted. This is very much a marathon and not a sprint, and we've worked really hard to put in sustainable processes, but we will be, at the risk of sounding provocative, we will be very conscious of being selfish with our management of those resources at the moment, because they are under pressure. Thank you.
Great, thanks Susan, thank you Adam. Happy to answer any questions.
Can you just explain the extent of strain hospitals have been under in recent weeks or months to justify this measure? We've been hearing from doctors and nurses that standards have been slipping and ratios haven't been met. Was there a certain threshold that was met that kind of justified taking?
The threshold is the combination of the real challenge, and perhaps Adam can speak following my comments, the real challenge of the impact of staff who have to furlough, staff who are in isolation, as Adam said, averaging around 5,000 healthcare workers every single day, alongside the surge in hospitalisation as a result of the Omicron variant wave. And whilst, as Professor Sutton said yesterday, we may well be at the peak or reaching the peak, that impact will be felt in our hospitals, in our IC beds over the next 2, 3, 4 weeks, with an already exhausted workforce, as we've heard from Susan. But it's really the combination of staff absences as well as the highest hospitalisation numbers that we have seen throughout this pandemic means that now is the right time to implement this system-wide Code Brown. And I just want to make the point and stress the point that this is something that we have been planning for. We said late last year, as we were coming out of lockdown, that we want to stay out of lockdown in line with national cabinet decisions. We want to stay out of lockdown, but what that will mean, particularly with this Omicron wave that is so infectious, is that there will be extraordinary pressure on our health system. So we've known that it's been coming. We've been planning for it. Our hospitals are very prepared for the further work that we need to do. And we've been making changes along the way. Hospital in the home, COVID positive streaming, a range of things that our health services are already doing. Now it's time to take the next step to Code Brown as we prepare for the significant increase in hospitalisations over the next few weeks. But I might ask Adam to add to my comments, and then we can answer some further questions.
Thank you, Minister. And as the Minister has said, it really is that combination between the rising COVID admissions and also the number of staff not available to work. And really that's generating the pressure at the front line. So Susan and her colleagues in emergency departments across Melbourne really very much welcome this move. It gives recognition to the pressures that they're facing every day, not only to treat patients coming into the emergency department, but also the pressure and challenges we're facing actually being able to staff those departments and other parts of the hospital shift by shift. So this really is a message both to our healthcare workers that we understand and recognise the pressures that you and the system are under, but also a message to the community around the seriousness of the situation and the extent of the strain upon the health system.
Did the modelling, Adam, predict that we would hit a point where we would require a Code Brown? The modelling going all the way back to October, and then when it was reviewed again, did it predict we were going to hit this point? And has it come? Has your declaration come, say, earlier or later than when was predicted?
No, the modelling doesn't specifically look at or indeed consider the option of a Code Brown. The Code Brown is very much our operational system decision about when we believe the pressure in the system is sufficient that we need that response. But the modelling itself does not predict when a Code Brown or suggest when a Code Brown may be required. In terms of whether we're ahead of the modelling, the number of admissions for COVID is growing fast, and we believe therefore now is the right time. We don't want to leave this decision too late, which is why we believe now is the right time to take this step.
How has this been avoided? I mean, could the planning been better to avoid a situation we got to a Code Brown or such pressure on the hospital's been going for 2 or 3 weeks? Given the experiences of 2 years of pandemic, could this have been avoided?
It's probably important to emphasise that calling the Code Brown is really going to assist us to manage the situation we're facing. So it enables us to really focus in and ensure we can prioritise access for those patients who most need it. So this is very much about prioritising our emergency and urgent care services to reassure the community that if you need that level of care, be that for COVID or non-COVID related reasons, then you're still going to be able to access it. We very clearly believe that now is the right time to take this step, and we've been planning, as the Minister outlined, throughout last year in Wave 3 and throughout the past few weeks as we faced the Omicron wave, for how to respond. And this is a planned part of our response to Omicron, and it's very much needed now in this position, and calling this 2 or 3 weeks ago would not have been the right time.
Adam, will nurses have to operate too?
Staff will react to this given
So overall, I think staff will welcome this, and I can talk about that from my own experience at Austin Health. So our emergency physicians, our intensivists, our nurses and medical staff and all of the support staff working on the COVID wards will welcome this, as I said, because it recognises and validates the work that they're doing and the pressure that they're facing every day. When I mentioned before that an option under the Code Brown is that some services may need to get to the point where they defer some leave, that really is a decision that we taken at an individual hospital level, and it really will be a decision that's only taken if it's absolutely necessary. I would stress we're all conscious of how tired and fatigued our workforce are, and that this is going to be facing us, this situation is going to be facing us for several weeks ahead. So we would only take that step if it was absolutely necessary to ensure that we continue to provide services.
Will nurses have to operate outside of established patient to staff ratios, and will they have to, say, do 12-hour shifts, where I'm aware of one hospital that has told their staff that already?
Yeah, so including during Wave 3 last October and November, and indeed now, hospitals are having to respond to the workforce shortages that we're seeing. And that's across a whole range of professional groups, but particularly nursing. So one way that many hospitals are managing that is to rely on what we call team-based models. So if we can't staff a particular shift with the normal number of registered nurses that we ideally would do so, then we will supplement that with other staff. They could be physios, they could be OTs, they could be medical students, but we will always make sure that they are trained to undertake those roles and that they work under the supervision of a trained and experienced nurse. But we do that in order to support our staff on the wards and to ensure that we can continue to keep our services open to the community.
But what about ratios and shift times? Will that come into factor with this Code Brown?
It will do, and in different hospitals on different shifts, the ratios will come under pressure, and that's why many hospitals will, when required, rely on those team-based models. But it's important to stress that where it is possible, hospitals are still seeking to operate and apply the nurse-patient ratios. That's our preferred position. We will only move outside of that in consultation with our staff and by putting in some of those mitigations that I've just outlined.
Do we need to be increasing the capacity of, now with people registering their own RATs versus going through the PCR system, which then triggers a support process, do we need to be increasing the support that is there rather than just a text today or something along those lines? Is there a way that we could be furloughing even further and relying on people to actually come forward with their symptoms through a process like that?
So it's important to stress that we're now able to register positive rapid antigen test results for members of the community who receive those, and that will then trigger their entry into what we call our COVID Positive Pathways program. So that will happen in exactly the same way as if you register a positive PCR test. So you will be assessed as a positive member of the community through a rapid test, the same way as you would be through a PCR, and then you will potentially be able to access the same range of supports regardless of the type of test that you've taken.
Is there enough capacity though in those services? Say if you ring one of those helplines previously, from personal experience, it's very hard to get through, or you don't get the callback that perhaps you were hoping for, and therefore people could be becoming more panicked, therefore they call an ambulance, and then you've got that flow on. So do we need more capacity there?
Yeah, look, we recognise that the growth in case numbers over the past few weeks has put enormous strain on all parts of the system, including the COVID Positive Pathways program as well. But we've adapted and remodelled the program to try and deal with this situation. So we're now, anyone who tests positive and registers that positive test, if it's a rapid test, will automatically be contacted via text message and asked to complete a survey. And then based on the responses to those surveys, we'll assess what level of support they may require. It's also important to stress that we're putting more information out to be available to the public so people can understand and recognise the symptoms of Omicron or indeed COVID more generally, and to give them support and guidance that's easily accessible to be able to assess whether you're symptomatic and wherever possible and safe to do so, to be able to self-manage at home or to seek support through nurse on call or through your local GP.
Do we run a risk with these measures of people being scared off from coming into hospital?
No, so it's very important that what the message we're trying to give here is that if you are unwell, then you should seek medical care and attention in the way that you normally would. But what we are asking is If you are not too unwell and you're seeking advice or information only, then there are other quicker, more accessible means that you can gain that advice rather than calling 000 or come into an emergency department.
One option to deal with the staff shortages could be to allow asymptomatic COVID positive healthcare workers to come into work. Is that something the government is weighing up at the moment?
No, so last week there were changes made to the furlough guidance so that staff who are close contacts of a positive case can now, in negotiation with those individual staff members, return to work if that's the appropriate thing for them to do. At the moment, we have no plans for asymptomatic positive staff to return to the workplace.
Our ICU admissions at the moment are lower than they were during the Delta peak in October, even though our general hospital admissions are much higher. Is the biggest part of the problem the combination of those thousands of furloughed staff and the fact that you've got a lot of people in hospital for reasons other than COVID who still require that COVID infection control? Is that what you're dealing with essentially?
Yeah, so definitely the staff absences are a large part of the challenge we currently face. But as I said before, it's the growing number of COVID admissions that's also putting pressure on the system. And those COVID admissions, those people may be admitted primarily for reasons related to COVID, or they may be being admitted for other reasons, but they happen to also be COVID positive. I can't give you a breakdown on the current number, but that's the mix of patients that we have in hospital at the moment. And it's also important to stress that non-COVID related emergency and urgent care is still being provided. So we're still seeing a whole number of people appropriately present to ED and be admitted to hospital for no reason at all related to COVID.
If we look at Victoria's last two big COVID peaks, the Delta in October and the 2020 peak, the ICU peak actually came very slightly earlier than the case peak, and I think that was probably because of delayed reporting of positive test results. How certain are you that you are going to see that surge of hundreds of more hospitalisations in the coming days, given that case numbers appear to be going down?
I think it's important to stress there's no certainty about this. We have modelling to guide us. We also have experience from other healthcare systems, including New South Wales, Canada, the UK. There's no certainty in that, but based on what we see happening elsewhere, our expectation is that both case numbers and COVID-related admissions will continue to grow over the coming weeks.
May I please ask our nurse?
Sorry, can I just
Yeah,
follow
sure.
up on that one? You said earlier that 1,500 would be achieved, or was it trigger number? We haven't reached that yet. Do you anticipate we will reach that?
Yeah, so the number of admissions does fluctuate day by day. So you would have seen yesterday we were up at around 1,250. That's dropped slightly today. But the trend over the past 7 to 10 days is a significant growth. So we've almost doubled the number of COVID admissions over approximately the last 10 to 14 days in hospital, and it's that trend that we're responding to here today.
May I ask our nurse colleague a question? Thank you. Can I just ask you, on a personal, practical sense, well, the government and the hospitals calling a code brown, what might this mean for you personally when it comes to your workload? And also, so did you have any leave planned that, you know, may have to think about twice, or your colleagues?
Yeah, look, I think, as I said before, we're very supportive of it. I think it sends a very important message, one, to the staff who've worked extremely hard over the last almost 2 years, about the fact that everybody acknowledges the workload, the exhaustion and the pressure that the healthcare system is under. I think from our point of view, we have limited resources because we are exhausted and we are faced with the same community exposures for our staff with work furloughs. We sit in a very interesting space because we've actually had quite a lot of staff who had planned leave, and leave has changed because of, you know, family infectious rates, or, you know, just they are choosing not to travel. So we assess that on a case-by-case basis. We absolutely acknowledge that our staff are our greatest asset. So we need to make sure that we have a sustainable workforce. So as far as leave goes, we look at the individuals in question. We absolutely see this as a last resort. And what we did as a proactive measure is we tried to maximise leave for the greater majority of our staff. So what we did was create an opportunity for people to take short blocks of leave, but have more stuff rolling into leave. So it means that everybody should be able to get a small break, because we need to be able to sustain this. It is about self-preservation at the moment, so we don't want to rob Peter to pay Paul. And we want to make sure that we're bringing the best to the table and promoting best patient outcomes. So the staff need to be in a space where they are safe to work.
Susan, you obviously know the system inside out and have been on the front line for months now. Are there things that you can see beyond the hospital doors that could be done to help ease the pressure on you? Things like furloughing from home, hospital tab care, that sort of thing?
Yeah, look, I think emergency nursing in the time that I've done it over the past 27 years has changed significantly, and this is probably one of the hardest things that I've ever had to do. And I think the landscape of healthcare has changed significantly, and we've had to be more proactive and progressive in our models of care and the way that we think. And I think, you know, we have invested significantly in some really good initiatives that are community-based. What we need to do is send messaging out that we are not compromising patient care by referring to those community systems, and we really need people to exercise good judgment. Now is the time, if you're not vaccinated, to go and get vaccinated. We never articulated that by getting a vaccination you wouldn't get COVID. We just knew that it would reduce the burden of illness. So there is absolutely still merit in doing that. We need people to manage their symptoms effectively. Don't go out if you are symptomatic. It really is our opportunity to put this back onto the community to say, please consider us in the decisions that you are making at the moment.
How many staff have you lost who are refusing to get vaccinated? How much did you stress that put on them?
Not a lot. We spent a lot of time. I think the last 20 months, as I said before, our staff are our greatest asset, and we put in such resources to maintain safety with our PPE and our systems and our model of care. So that additional option of having a vaccination was really just the cherry on top for us, because why go to those efforts to create that level of safety and not be vaccinated?
But I guess how many, I know the exemptions how many national health system was, it could be working now.
Thank you. I don't have the number available to me now, but I don't have that number available to me now. We can take that on notice. I do know at an Austin Health level, just as an example, the number of staff who chose not to get vaccinated was a very small percentage of our overall staff. We spend an awful lot of time supporting and providing advice and guidance to our staff, and the overwhelming majority made the decision to receive the vaccination. And we're now just working with all of our staff to encourage them to take up their third dose, because that's the best way that they can protect themselves, their families, friends, and indeed the patients they care for as
Would
well.
the percentage of Austin staff who refuse be higher or lower than the 6% of the general population?
I'd have to take that on notice, but I believe it will be lower than that figure that you've just quoted. Yeah.
What kind of staff shortages are you seeing on average in hospitals at the moment? Is it 10, 15%?
It's very hard to give you an average, because it really does vary from hospital to hospital and indeed from shift to shift. What I can say is the greatest challenge we're facing is often at an Austin Health level, but I know at other hospitals around Melbourne, actually being able to staff our emergency departments. They really are at the front end of this. They're facing the pressure not only of the COVID demand, but all of that business as usual non-COVID demand as well, and trying to operate in an environment where they're having to set the departments up in a very difficult and different way than they would normally operate in order to manage both suspected COVID and confirmed COVID cases. So it's the emergency departments, our COVID wards, ICUs, they're the areas most under pressure in terms of staffing shortages.
Overnight, a video surfaced from a young woman from ex-colony talking about her IVF journey and how it's been interrupted because of what's been going on. Are people like Melanie going to have to wait longer now that this program has been?
So we're going to do everything that we possibly can to resume IVF services as quickly as possible. I've got some dear friends who are currently going through IVF or have been through IVF, so I know what an emotional toll it is, what a financial toll it is, And this is in many cases a last opportunity to create a family for themselves. So I am absolutely empathetic, and the message I want to send today is that the moment we can boost or return to services for IVF patients, we will absolutely do so.
Does that look important to you though? Because we don't like to go down, or as soon as possible, perhaps next week, tomorrow?
Yeah, so I don't want to align it with the timeline that Adam's taking us through in terms of Code Brown, which the advice from our health service will be around 4 to 6 weeks. I don't want to tie up the question around IVF with that time frame. We are doing work right now in regards to IVF services. I understand how critically important this is. I understand the emotional, financial toll that going through an IVF process has on individuals and their families and their friends, and we want to return those services as quickly as possible. So we're doing work right now on that.
I know there's no ideal
When you
time.
say that you're specifically looking at IVF right now, are you looking at what specific clinics can reopen in in settings where those staff aren't needed in the public system? What
Yeah.
are you specifically doing to get it back up?
Obviously, I'll have some more detail when we're in a position to speak further about what we can do around IVF services. But I do want to stress today that we understand the imperative, the importance, the critical, the criticalness of the timing of going through IVF procedures. So we are looking at what we can do right now to improve services. So I'm hoping that we'll have more to say shortly. But I just want to acknowledge the issue right now. It is not connected to what we've just announced today in regards to Code Brown. We are looking at what we can do to improve services.
Does it have any impact on the Code Brown on breast screening, bowel cancer screening, all of those things that we've been telling people consistently through the pandemic? Still go and get those tests done?
Absolutely, still go and get those tests done. I might ask Adam to comment further. A couple of things I wanted to say and stress. Every single clinical decision remains a decision of clinicians. Nothing about this Code Brown announcement, the health services activating their Code Brown plan changes that, and as always has been the case, the sickest patients get treated first. In regards to screenings and other like procedures, I'll ask Adam to speak.
Thank you, Minister. As the Minister has said, we will make every attempt to maintain service provision, particularly for those cancer screening and diagnostic services. So they will only be impacted by this if absolutely necessary, if the workforce shortages in particular require that. But at the moment, we're making every effort both to maintain Category 1 surgery, but also cancer-related diagnostic and screening services.
Another question. I know there's no ideal time for politicians to take leave in the middle of a pandemic, but we had the sports minister on leave amid the Novak Djokovic saga. We've got the health minister on leave when we're declaring a Code Brown, and we're asking some health workers to come back and defer their leave. It's not ideal timing, is it?
Oh, look, I think as Susan talked about, it's important that everyone gets a break. I can tell you that outside of the Premier, no one in government has worked harder than the Health Minister to support our health system as we deal with this pandemic. Martin has worked extraordinarily hard. He's worked himself into the ground. He's taking a couple of weeks off with his family, as he should, as everyone should. This has been an incredible toll on everyone in our community, and there's never a right time to take leave during a pandemic, but no one has worked harder than Martin Foley. And on his last day, I had a chat with him, and I said, "Don't call me. I want you to have a break because you need it." He's been fantastic, and I look forward to when he's coming back. But he needs a break just like everyone
James,
else.
the other people who need a break are the healthcare workers who have been working extremely hard over the past 2 years. I mean, don't you think that, it's not ideal when Code Brown, this is the first time we've ever called it. Are there measures that we could have considered earlier on to avoid getting into this mess? Not to doctors and nurses believe that they're the sacrificial lambs of the left-fit approach. Do you agree with that?
Well, there's a number of things in your question, Timna, that I don't agree with at all. This has been something that we have been planning for because we knew that we would get to this point. When you've got a variant that is so incredibly infectious, even though it may be milder, the sheer numbers of infections means that it is going to have an impact on our health system. The fact that we can enjoy freedoms in our community as individuals, as families, is on the shoulders of every single healthcare worker in Victoria. They have been incredible, but they are right now under severe stress. As Adam pointed out, it would have been a wrong call to make this Code Brown announcement a few weeks ago. It would be a wrong call to make the Code Brown announcement 3 weeks down the track when our hospitals are absolutely overwhelmed with COVID positive patients. The right time to activate in a system-wide way Code Brown is right now.
Are you worried about the amount of cases we're seeing in aged care homes? Is that something you're discussing with the about how we're handling those cases at the moment?
There's no doubt we're keeping a close eye across all our settings, particularly sensitive settings, whether that's aged care, whether it's mental health, which I'm responsible for. We're keeping a close eye on numbers, on vaccination rates, on third dose rates within all of those sensitive settings.
Spoke to teachers about the concerns that they have about the return to work protocols and exemptions like tomorrow. Teachers have expressed they're very concerned about going back early, 15 close contact, especially with the lack of rats, as well as just concern of.
Yeah, there's a few things, Rich, in terms of return to school and across the board, all of the settings, all the mitigations that we've been putting in place over the last couple of years, and what we're looking to do to put in place for the return to school on the 31st of January. There's constant dialogue with our unions in education, with the principal peak bodies, with other organisations to make sure people are aware and engaged on what are the mitigation strategies. In terms of the exemptions for critical workforces, and education is a critical workforce. We've seen that over the last couple of years. There's two really important points to make in terms of the exemptions. One, it is voluntary, and secondly, there's a requirement for a daily negative rapid antigen test every day for 5 days. It is an important mitigation, and it is voluntary. In terms of the other settings that we'll put in place for the return to kindergarten and the return to school, I'll have some further announcements in the not too distant future. There'll be some further discussion about back to school at National Cabinet later this week. Then we'll make some announcements in terms of the back to school plan in Victoria. And it will include all of those things as Professor Sutton outlined. The exemptions for critical workforce, the use of masks, the importance of rapid antigen tests, all the other COVID safe mitigations. In terms of the air purifiers, we had a target of 30,000 by the end of last week. We've reached that. We are on target to reach 40,000 air purifiers by the end of this week. We will meet our obligation in terms of those 51,000 air purifiers across schools across Victoria. No other jurisdiction even comes close to what we're doing in Victoria. So I'll have more to say. We haven't finalised the plan. There'll be a discussion at National Cabinet, but we will have students back at school day one, term one, in a very, very safe environment.
If the state make rats freely available to teachers in the essential workforce out of that filing of 44 million?
Yeah, Rich, I appreciate the question. I can absolutely confirm that rapid antigen tests will be a critical component of the back to school plan in terms of exactly how that will work. I'll announce that in the not too distant future as we roll out the back to school plan. We will give principals and staff and parents plenty of time prior to the start of school on the 31st of January but it'll be a few days away.
New South Wales
Will
is
they be
mandating
able to
2 rats
get
a
them?
week for students returning to school. Are we going to do that until we have the rats to do it?
Again, it's the same answer. Rapid antigen tests will be a critical feature of back to school. In fact, rats are a critical feature of how we respond to the pandemic. I would love to have more rapid antigen tests in Victoria and in this country. We have not seen a quick national approach to procurement of this in-demand global product. We are doing the best that we can. We've put in an order for 44 million rapid antigen tests. We've seen the first allocation of 3 million. There'll be significant deliveries over the course of this week and over the course of the month. We will have more to say in terms of how that will be applied for students and staff in a school context.
Will families have to provide them, or would
Again, I'll have more to say about provision of rapid antigen tests for staff and for students, but we'll do so following National Cabinet.
Across the
Last
board, though, the
question.
longer that it takes to spell that distribution plan out, the more we're fostering this black market of sorts. You know, we've got a cafe that was saying if you spend $160 here, you can get 2 free rapid antigens. They're selling out in minutes at Chemist Warehouse every time they do a shipment. What are we doing to try and make this? It's really not.
Yeah, there's a couple of things. One is we have seen reports of really unethical behaviour in terms of price gouging of rapid antigen kits. That is disgraceful. It shouldn't happen, and particularly at a federal level, we need to stamp down on this in terms of what we can do at a state level. And again, like so many things throughout this pandemic, it's been left to the states and territories to pick up what should be national responsibilities. Now we are doing our bit to procure and deliver as many rapid antigen tests as we can to critical workforces and communities across the state. That is exactly what we're doing. It would have been great if there was a national approach much earlier to deliver rapid antigen tests.
Is the government considering appointing a rat commander?
I'm not aware of that. I think we've got the systems in place. We've got the procurement in place. DJPR is responsible for securing it, and then DH is responsible for delivering the rapid antigen test. I'm not sure that we need any other bureaucratic changes that might happen. I just don't know.
Surely we don't need another commander. Just on the back to school, what do you expect to see in the way of increasing infections once kids go back to school, and the closure of schools as people are furloughed?
Yeah, I think there's a logic, and we see it in the numbers. The numbers of infections during school time, and then obviously during school holidays, the number of infections for children decreases. So there's a logic to back to school. Omicron is impacting on every walk of life, and we're seeing those numbers either in our own households or friends and family. Everyone knows someone who's positive with Omicron. Sorry, the second part of your question?
Just closure of schools, you expect there'll be a high proportion of schools closing naturally?
So what we support is are the principles agreed at National Cabinet, that national framework for return to school, and the overwhelming principle are that schools are the first to open and the last to close. The days of system-wide remote learning in line with lockdowns, no one is talking about that. We want our students back in classrooms, face-to-face with their teachers, with their peers. What we're doing is all of the mitigations, all of the things to support getting our kids back in the classroom for the start of term.
just on today's 22 dance conference,
The back to school plan is discussed with National Cabinet. Will that be a national plan or national approach? Will you be pushing the federal government to supply rapid tests specifically to schools so that we don't end up using them out of the 44 million? Is that something that you're pushing for?
So there'll be some further discussion, and this was agreed at the last National Cabinet, agreement of the principles, and then there'll be a further discussion at National Cabinet. What comes out the other end of that, the other side of that, I don't know. That will be subject to the discussion that the Prime Minister and First Ministers have at National Cabinet. In terms of rapid antigen tests, look, we have been pushing the federal government as hard as we possibly can, as have other states and territories. What we need to see is a national approach to procurement of rapid antigen tests. We needed to see that months and months and months ago. What we are doing is ordering 44 million. We've got the first significant delivery of that procurement, and we'll get that out to vulnerable communities and critical workforces as quickly as we can. No, I'm not saying that, and this will be, we're looking at what supplies we receive in addition to the 3 million over the course of the next week or so, because you don't know you've got it until the plane's actually landed and you've got it in your hands, and then you can make very confident commitments, whether it's to education, early childhood or other cohorts. Then you can make confident commitments about what that means.
Just on the 22 deaths reported today, you said that 11 of those 22 were people who died over the past 2 days. Are the other 11 the result of coronial inquiries, or?
I don't have the breakdown in terms of the circumstances for each of those 11, but I'm happy to come back to you. All right. Thanks all.
Thank you.
Oh, thank you very much.